Welcome to Reducing Risk, a series of podcasts from Medical Protection created specifically for clinicians in Aotearoa, New Zealand. Reducing Risk looks at key medico-legal issues in our jurisdiction and provides helpful advice and guidance on how to manage those risks. Today we have a special guest with us, Dr David Maplesden, who is an experienced GP in the Waikato. David is also the in-house GP expert for the HDC. And whilst it might seem that we naturally have an adversarial relationship with David, I know that ultimately he has the same aim as us at MPS, in that we want all GPs to be practising safely. And that's not to say that we agree with all of your opinions, David, I'm sorry, but often we do. These podcasts we are doing with you will be friendly, but hopefully also a little challenging. This will be part one of a multi-part series. So welcome, Dave.
Thank you, Sam.
Nice to have you here. Thank you for coming all the way from the Tron. We also have in our studio Dr Tim Cookson, who's a retired colleague of mine from MPS and GP. Welcome, Tim.
Hi, Sam.
And we've got Dr Lucy Gibbard, who's a current medico-legal consultant with me at MPS and also a GP.
Hi, Sam.
So it's nice to have 4 GPs in the room. So, David, to start with, tell us about your role.
My role with HDC specifically, which I've done since 2009, it's titled in-house clinical advisor. So I do currently 26 hours a week, basically reviewing complaints and provider responses and supporting information to provide an opinion on whether the actions of the provider, mostly general practitioners, has met expected standards. So there's lots of kind of variables in that job. So essentially it's to provide an opinion on whether the GP's actions were consistent with accepted practice or the degree to which they departed. I also get to look at non-GP issues and complaints, and there it's really to provide a steer on clinical issues, interpret the technical aspects of the responses. Often, I don't provide a formal opinion in those cases, but it's really a steer to the complaints assessors on which way this complaint perhaps needs to go, whether the provider response has been appropriate, and whether it's consistent with the clinical notes, for example. It's on a background of I think just over 40 years in general practice. So I've done all sorts of things in general practice, 20 years in a large urban group practice, but initially solo practice, doing obstetrics at the same time, so delivering about 50 babies a year. And then about 18 years of part-time general practice, including rural locums, remote rural locums, but a lot of urban practice as well. So coupled with that, I've done PHO work, clinical advisor and GP liaison work, currently still peer group leader for my general practice peers, and for about, I think, 12 years or so I was chief examiner, written for the College of GPs written exams. So all these roles, or some of these roles, make me triply unpopular, I think. The writing the written exam and working for HDC, it's a double dose really. But I've got a real interest in patient safety and clinical governance. And that really stems from early in my career when I made some pretty significant errors, late diagnoses of cancer, 2 in about 2 months, lung cancer, and it really made me look at why do these errors occur, how can we stop these errors occurring, and that's kind of evolved into where I'm at now.
Wow, you've done a lot of things in your time then. Makes me think I'm an underachiever.
Not as many of my colleagues.
But it is interesting, isn't it, how those early experiences really can have a significant influence on your future direction in practice. And I think it also applies in the other direction, that sometimes those experiences can be disastrous for doctors, can't they? Especially if they end up in front of the HDC, and then all those impacts that can
Absolutely. And I think I was lucky with early in my career the HDC didn't exist. So the patients certainly weren't happy, but I had to learn how to deal with that. And then later in my career, I still make errors, as we all do, because no one's immune from them. But I think I learned how to minimise the risk of it going further than than in-house, by learning how to apologise to patients and handling complaints at a much lower level than escalation.
That's a really good point you make. I think that the HDC's workload would be much reduced if we all learned how to do that.
Yeah, I was giving a talk to some GP1 registrars the other day, and I really just pushed that whole concept of the lower the level you can resolve this complaint, the less stressful it is for you, the more beneficial it is for the patient, and really that should be your goal. Encourage your medical centre to receive complaints and have a really good complaints handling process, and you'll I think very much reduce your risk of things getting to that complex, extremely stressful level of HDC.
I think it's interesting though, because if you Google "I want to complain about my doctor," what pops up is the HDC, and it's a lovely web form that you just fill in. And it would be really great if when you Googled "how do I complain about my GP," what came up is a system that fed you into the practice system, the practice complaint system, rather than fed you straight into
Absolutely.
the HDC.
And it may be more about having it obvious within your practice. Like signs or whatever. And the other issue I think is really encouraging patients to use the Nationwide Health and Disability Advocacy Service, because they get thousands more complaint contacts a year than HDC does, and a huge majority of those they will deal with without it coming to HDC. So again, if you can't resolve it in-house, then if you try and encourage that as the next level of resolution, again, you'll avoid complaints coming to HDC.
Can you perhaps expand on the advocacy service? Because many of our members may not sort of know much about that, so that's interesting too.
So the advocacy service, it's kind of separate to HDC and not, and that my understanding is it is contracted by HDC to provide low-level resolution of complaints. So I think a majority of complaints will be resolved without any sort of HDC contact at all. If the advocacy service feels they can't resolve a complaint, or the consumer's unhappy with their attempt at resolution, then they can escalate it to HDC. But conversely, one of the ways of HDC handling a complaint is to refer it to advocacy. So it's useful all around, really.
So it's a kind of a mediation service, but they don't make any decisions on the quality of care or anything else like that.
No, they resolve it without, there's no expert advice or anything along those lines. What they may do is they may facilitate a response from the provider, and help the consumer look at the response and whether they're happy with the response. But there's no kind of external advice that's sought by them.
I found that the advocacy service over the recent years have really improved, and I think they do a great job, especially for patients who perhaps aren't particularly health literate, who don't quite know how to get their point across, or who might be a little confused. The advocates seem to have a way of being able to order their thinking and put it in a coherent form so that the doctor can answer it.
Absolutely.
They always have that bit at the bottom that says, in order to consider this complaint resolved, I require this, this and this.
Yes.
But it's kind of really, it's so easy to answer that then, because you actually know what the patient wants, which often in a complaint directly from a patient, sometimes it's quite hard to know what the patient wants.
Yeah, and that would certainly be one of the reasons why HDC would send a complaint and complain it back to the advocacy service, because it's not clear from the complaint exactly what they're trying to achieve, or that level of health literacy doesn't enable you to identify the issues.
I think it helped the advocacy service significantly when their role, or their description of their role, changed to assist a consumer to make a complaint to assist the consumers to resolve complaints, and that shift in attitude really made a big difference in terms of how things ran.
And I think that's by reinforcing that is the prime aim, getting resolution at this lower level. We might, I think would encourage practices to use their services.
And I've often pointed out to members who are wondering, why should I bother to do a decent response to to an advocate, that actually the advocate can end up being their supporter, if you like, because if you put a really clear explanation as to what happened and why it happened and all the rest of it, then the advocate can then explain that to the consumer, and much more likely to get a response.
Absolutely,
because they kind of act, again, as a mediation in that regard, even if they're not trained mediators.
That's
I've
true.
always found one of the things that's a bit sad is that the practices can't refer to the advocacy service. A practice who are struggling to come to a resolution with the patient directly, the practice can't go to advocacy and say, help us. It has to be the patient going to
That's
advocacy
right.
to say, help us. Whereas actually there are some situations where you think with the practice it would be really helpful for the advocacy service to be involved.
Yeah, and again, I think it might seem counterintuitive to encourage a patient to use the service, but honestly, it's going to be beneficial for you to have the pamphlets, give the pamphlet out, and just really encourage use of that service.
And as you pointed out, having any complaint resolved at the lowest possible level is the ideal, and certainly the advocacy service is a much lower level in terms of stress than the going to the HDC itself.
True.
Much shorter process too, shall we say?
Yep.
So it can't be an easy role, David, providing your expert opinion for the HDC about your GP colleagues. As you'll be aware, clinicians tell us that the HDC process can feel adversarial and fairly brutal at times. So how do you approach your role in terms of what do you see? How would you explain what you're doing in terms of what you believe the positive parts of your role are, if you like?
Right. Well, I mean, from the outset, one of the most positive parts of the role for me has just been essentially seeing the high standard of medicine that the vast majority of my colleagues practice. And I think I've learned more from being in-house advisor about medicine than I ever learned at medical school. So how I go into it, I mean, for a start, for me, it's an inquisitorial process, not an adversarial process. So for me, it's here's a complaint. On the face of it, it might look quite significant. I want to make some inquiries to see, well, what actually happened? Is it as bad as it sounds? What were the mitigating factors, etc. So I certainly don't go in saying my role is to be to support the patient over the doctor or to support the doctor over the patient. It's a totally objective role, and basically it's just to provide an opinion. And again, it's an opinion. It's not gospel. I'm not always right, but to provide an opinion on whether the standard of care met what would be regarded as accepted practice. So I know from the start, I know that there's very rarely an intention of any GP to go out and harm a patient. The only exception to that are the few disturbing transgression of sexual boundary situations I've seen, which some have been pretty horrifying. But there's no other time that a doctor is going to go out to deliberately make an error to harm a patient. So I think that's a useful starting point. And I always do what I used to call the mum chair and the chair. So the mum chair is reading the complaint. Every patient has a story. Every complaint has a story. So thinking, well, why is this patient complaining, and try and put myself in their position, but equally to then be sitting in the GP's chair as this patient comes in or as they come in, sequentially, and what other factors are in play that might be influencing the way the doctor is interacting with the patient or providing a service. So really trying to put myself there and basically thinking, well, what would I do? What is guidance around managing X, Y, or Z condition? What are the factors that might influence my comments or perception of what went on and why? So really trying to be objective. What is difficult is avoiding hindsight bias, of course, and I'm acutely aware of that. And so I've adopted a method of analysing a case sequentially and commenting sequentially. So rather than saying the patient died of X, therefore at Y point, this must have been happening, it's really just looking at what was happening at this specific time, what information was available, and information will accumulate and the situation will change sequentially. So my comments that up to this point management was fine, but beyond this point there might have been some departure because of the additional information that came in. So I think that's one way of trying to avoid hindsight bias. And the cases I think that are particularly difficult are, and I've seen a few of these sadly, are things like missed sepsis. So particularly with children, where the patient's seen and dies at home, 12 or 24 hours later. I've just trying to to say, well, look, irrespective of what happened, the clinical signs in the picture at this time were not suggestive that this patient was going to die 12 or 24 hours later. So management was fine. And those decisions are quite hard because obviously it's difficult for the family to come to grips with the fact that this can happen, that this is how illnesses can progress sometimes. And I've seen cases where, in fact, a child has been sitting in ED being watched and then suddenly decompensates and dies, in ED. So it's certainly not confined to general practice.
So when you're preparing your opinion, what information do you have? You've got the complaint, you've got the doctor's the notes,
yeah.
And do you have the response of the doctor to the complaint?
Absolutely. So so essentially, when a complaint comes in, it's triaged. There's limited clinical input into the triage situation, which we work on. We've been trialling increased clinical input, but essentially, from triage will come a decision as to what happens with the complaint. So again, without going into too much detail, there are numerous ways a complaint can be handled. What we're trying to do more and more is send it back to the provider to resolve, which I think is quite a reasonable way of doing it. But there are other sort of professional areas, regulatory bodies that can go back to. It could be out of jurisdiction, it can go to Privacy Commissioner, it can go to Medical Council, etc., etc. If it's to come to me or any other expert, if it's felt that might be useful, then there should be a specific request for clinical notes, response from the provider, any additional information the provider might want to add. And that's about as far as it goes. Obviously, if it goes into an investigation at any time, then more information, including things like interviews and transcripts of interviews, phone calls, etc., might come into play.
So obviously, when we write notes as GPs, we try and put as much as we reasonably can in, but that's only a small proportion of what actually happened. If the response that comes in from the doctor is much fuller and sort of has an explanatory bit, does that influence how you assess the case?
Absolutely. So I will always refer to the clinical notes and to the response. And again, it's not up to me to make a finding of fact as to whether what's in the response is accurate or not. So I can't prefer one version over another version. That's up to the decision maker to decide. So what I might have to do is say X scenario, which is based solely on the notes, means X departure or not departure or whatever. But if the notes, if what the provider has said, even if it's not represented in the notes, is actually what happened, then care was appropriate, for example. So I think it is always worthwhile presenting in your response exactly what went on or your perception of what went on, even which may or may not be accepted by the decision maker ultimately.
Certainly one of our roles, in helping doctors prepare their responses is firstly to make sure that everything that's relevant in the notes is actually included in their response, and also that their response is not inconsistent with the facts that are in the. So we can't have a response going in saying, "Well, the notes were wrong," and that such and such didn't actually occur. Though occasionally people write things that didn't actually happen, so sometimes an explanation is needed. So it does make it complicated.
Linked with that, I'm thinking about clinical notes, and for some of us, our notes aren't necessarily very fulsome, shall we say. Is there any value when the doctors say, particularly if a case happened two years ago, say, if they say, well, actually, I do remember examining the patient, and I'm sure that this is what I found, but I just didn't document it. Is there value in that?
It's quite dependent on the situation, I think. And I mean, to some degree, you can have a suspicion based on subsequent events or even looking at the standard of notes previously, even if they're unrelated to the complaint, about how much influence or how much to let that influence me. And I guess, we've got to be realistic that if something happened 2 years ago and you remember examining the patient and finding their abdomen was soft, etc., I don't know that the decision maker is going to attach a huge amount of weight to that if they, had an abdominal mass detected by somebody else 3 weeks later, for example. But as with many of these things, decisions and principles, it's so context dependent that I can't say no, it's not worth doing, because sometimes it is worth doing.
Sometimes it is. Okay.
So to expand on that, sometimes we get the call, oh, look, I've just had a terrible disaster. I've tried to resolve it, but I'm sure the patient's going to complain. And one of the questions we might ask the person is there anything that happened that you can recall now that's not recorded in the notes? Because if there is, write it down now, date when you've written it, so that it's clear that it's a relatively contemporaneous account rather than 2 years after the fact. Would that alter how much weight you'd put on that?
Yeah, I think so. I think if it's written before there's a complaint made, or before something like they were aware that the patient died 12 hours after going home, then I think that it's well worth doing, and that would be considered almost along the lines of a contemporaneous note. Mm-hmm. However, even if it's recorded as not contemporaneous but has come in after the patient's complained, there might be more doubt cast onto how significant the added facts, if you like, are.
Yes, because there's a lot of hindsight that suddenly comes into that.
Yeah.
But sometimes it's actually recording the resource constraints as well, because actually you haven't written in the patient notes that you were working in urgent care, there was a 7-hour wait, you were 2 doctors down, and all those things that aren't going to be in the patient's notes. And yet it is actually really helpful if you can write those things down somewhere else when there's a complaint. Would you take those things into account?
Yeah, absolutely. I think often, I do often see that, and often that comes from, say, a practice manager response rather than the doctor themselves. And certainly in secondary care, in ED complaints, they will, they've got it all recorded electronically about how many patients were waiting and what categories, etc. So that is helpful to know.
Is it taken into account?
It's taken into account. So any what I perceive to be mitigating factors, I will generally list or mention. I'm theoretically not meant to consider those mitigating factors personally. It's fine for me to list them, but it's meant to be really up to the decision maker's role how much weight to put on those mitigating factors. I might blur it a little bit because it inevitably does affect what I write. But I think certainly having the mitigating factors there for the decision maker to also consider is really important. And those certainly would be regarded as mitigating factors.
You probably won't be surprised to hear from us that often we consider that the mitigating factors are not taken sufficiently into account by the decision makers. And as you say, that's not you personally, but it's a different part of the organisation.
Yeah. I think it's becoming an increasing issue, just the resource constraints and the manpower, primary care manpower issue, etc. And I don't know that there's an answer to that, because do we accept a lowering of standards as becoming the new normal because of these issues, these constraints? So from a systems point of view, I think there's a danger in accepting lower standards as a new normal. From an individual provider's point of view, it's probably not fair to be held to standards that were applicable 10 years ago, when there was a 3-day wait to see your GP rather than a 3-week wait.
And if you can comfortably only see 15 patients in a session, but you're asked to see 25, how do you actually provide the same standard of care to all those 25, knowing that if you don't see them, there are going to be consequences potentially for those patients not being seen?
That's right.
Yeah, it ends up being incredibly disheartening for our members to find that actually I was pushed to the limit and there wasn't more that I could do, but yet I've been hauled over the coals for it. And I know that's probably not, that's not hauled over the coals by you. It is the decision makers who make those, but it is incredibly disheartening. And you can see why people feel like actually it's time to go gardening.
Yep.
Yeah.
Which is sad, because it compounds the situation.
It does. It totally does.
Yeah.
So, you refer to, obviously, health pathways and guidelines in your opinions. And in considering the practical realities of being a GP, we can't be reviewing health pathways for every patient that we see. And so sometimes we don't strictly adhere to them. Do you take that into account?
Yep, I'm totally aware that this is guidance, not prescription. The dilemma I have is knowing what is accepted practice sometimes, because even though most of my colleagues, I'm sure, practice at an excellent level, there is still quite a significant inter-provider variability. So this it starts from the quality of clinical notes. So I'd see a huge variation in quality of clinical notes, which doesn't necessarily equate to quality of care, but there is a huge variation. And I see quite a significant variation in, let's say, a patient coming in with change in bowel pattern, and that's the only symptom, and how that is managed. So luckily, over the years that I've been doing this and reviewing, thousands and thousands of sets of patient notes, I've got some concept of what's kind of like a median approach to care. But and there are often very good reasons that guidelines have not been followed, because again, these are blanket guidelines that don't necessarily apply to somebody with X comorbidity or whatever. But I still find them useful to represent basic principles of what should be done. So not necessarily the detail of the guideline, but some of the basic principles, which I know are basic principles because that's what you're taught at medical school and that's what you should be doing. And it's useful to have something to actually cite to support my opinion in that way. If I was just saying, well, this is my opinion as to what should be happening, and without being able to support that with some sort of other opinion, if you like a guideline, then I would be challenged by you guys a lot more, I suspect.
What about how contemporaneous the guideline might be? So, if something's come out within the last 6 months, would you expect a GP to have read that? If it's only come out, 3 months before the incident, would you expect that to apply? So do you have some sort of guideline in your head for that kind of thing?
I think for the most part, it's probably not that relevant, because it's very rare for there to be significant changes to management in a short space of time that aren't widely dispersed. But let's look at say managing diabetes. So there've been a lot of new agents that have come in over the last couple of years. The guidelines have changed, but I would not be critical if those guidelines were not strictly adhered to in terms of your vildagliptin and all the other bits and pieces, because it is all relatively new stuff. But I might certainly say there's some departure, because this is what most doctors are doing now, and recommend an educational approach to ensure that provider is up to scratch with the guidance. Otherwise, I try and use guidance that was in place, certainly try and use guidance that was in place at the time of the complaint, if such a guidance exists. And I often might cite BPAC publications in that case. Where it becomes more important, I think, to be aware of very recent guidance are the things that come out of BPAC, MedSafe and Pharmac around new precautions with medications. So I've had several complaints about adverse effects of quinolones, this systemic response syndrome, whatever it's called. And there's a whole organisation of patients harmed by quinolones now that we may see more complaints in the future, coordinated complaints. But if MedSafe have put out bulletins warning, of this syndrome, and you need to be warning patients about this syndrome, those are the sorts of things I think that we need to be aware of. And if you're going to read anything, I think it's the prescriber updates and the MedSafe bulletins that come out in terms of safe practice.
That's really interesting, isn't it? That's the ones that you kind of hold at the highest level of needing to be read.
So I think from a patient harm point of view, and this all came to a head with the case of the coroner's case around the patient that died after changing their anti-epileptic formulation. I can't remember what
lamotrigine, was it?
The lamotrigine, that's right.
Yeah, I remember.
And I had I had several complaints along those lines, and I really had to look at what had come out into general practice to warn them, of when not to change or how to monitor patients after making the change, etc.
It's a real struggle, though, isn't it, in general?
I'm
thinking the recent one with nitrofurantoin used as a prophylactic, which I think there's definitely been some education out there to try and teach us all about the dangers of longer term nitrofurantoin. But even so, we all get so many emails and so many things, and we're so inundated by the inbox that actually I do feel a lot of sympathy and understanding for GPs who say, I just didn't know that.
Yeah.
And there's so much to know.
Yeah. Well, that was one of the reasons that in my work as GP liaison in the Waikato, which I've done for quite a few years. Initially, I used to take a paper version of recent updates, recent things of interest I've found, and just present to the practices that I was visiting. And that was one of the reasons why I've transferred that into the podcast, monthly podcast I do, which is really bringing in things that I think people might find useful in their practice and might enhance the safety of patients.
Those podcasts you do monthly with Joe Scott-Jones are amazing. They're really good.
Yeah.
So thank you for doing those.
They take a bit of work, but they're fun. I think.
Well, that's good that they're fun.
But that's maybe something that we could emphasise to our members in addition to this podcast. But that if you have to prioritise your reading, then this is an order of priority that you might want to consider, because that's how it will be considered if something goes wrong when it comes to.
I'm going to change my reading list now.
Guidelines are useful, but I think for the most part, they're really just writing down what we know and what we do anyway. But honestly, they're such an amazing educational resource as well. So things like, I've always had difficulty and felt a bit nervous about differentiating giddiness, the central versus peripheral causes. And I'd never heard of the head thrust test. And until I read the guideline, and then just use that all the time, because it just makes it so much easier to differentiate. And again, I see reasonably frequently misdiagnoses of cerebellar stroke because the dizziness has been put down to a peripheral rather than central cause. But I wouldn't be critical that the doctor hadn't done the head thrust test just because I now am a fan of it. But I would say, look, this is what the guideline now says, and this is a useful thing to incorporate into your practice.
I think I heard that podcast.
Okay.
Because, of course, historically it's been well known that there's often a significant gap between information being available and it becoming standard practice, and that's the whole reason the Cochrane collaboration was set up in the first place, was because of that huge time gap. I think it's lessened now with electronic information going out, but Lucy's right.
It's a bit overwhelming.
It's the overwhelming.
Are you going to read GP Research Review? Are you going to read what's coming out from the Medical Council with their update? Well, there is just updates coming from everyone all the time, aren't there?
I think I sat down and actually tried to write down all the sources once that would come into your inbox or email, and it's enormous. Yeah. And what I hate to think is that all our time is consumed reading medical stuff when there are pretty good novels out there. And then we're burning out because it's it's just too much. And you don't expand your mind just by reading medical stuff. So.
It's interesting.
On a slightly different tack, when, let's just say you've got a case where you've got a delayed diagnosis of cancer and you get all of the clinical notes, how wide is your brief? Do you look at the whole note and think, oh yes, they've seen somebody for a UTI here and a chest infection there, or they're treating their asthma badly? Do you look at those things and comment on them, or are you really simply focused on the complaint?
So it depends a little on the brief that's given to me, and unfortunately, I get a lot of please comment on clinical care briefs, which are just totally broad. Although I think the intention is that as it relates to the complaint. And on other occasions, I might get quite specific clinical questions, which is great because it's much easier for me to do in a much shorter length of time. But generally, for these please comment on clinical care, I will make the clinical care specifically related to the complaint my priority. I do review all the notes, and that has potentially positive and negative aspects for the provider. So from a negative point of view, if I pick up something that I think is a patient safety issue, then I will comment. So I looked at a case the other day which was related to delayed diagnosis of stroke, I think. But I picked up this patient was on triple whammy therapy and had been for a couple of years and had not had renal function tested over that time. So I would mention that because to me that's an opportunity for education and potentially a patient safety issue. And I might say, well, the recommendation is that X, Y, and Z testing takes place, etc. But that wouldn't be the basis for a breach because it's not related to the complaint.
So you'd never comment this was a moderate departure from expected standards?
I might say it's a departure from expected standards, but because it's not related specifically to the complaint, if it's related peripherally to the complaint, however, so if the complaint was that their AKI was missed, then definitely that would come into it. So I had a complaint some time ago where the patient actually complained about, I think it was about not being given antibiotics when the first lot didn't work for their cellulitis. And in fact, management was fine, apart from the fact that recorded in big letters was this patient is allergic to flucloxacillin, and they've been prescribed flucloxacillin, and nothing happened.
Is there a problem with that?
Nothing happened though, because 90% of patients that have a penicillin allergy don't have a penicillin allergy. But I had to say, if you've recorded someone has an allergy to penicillin and you prescribe them penicillin, unfortunately that's not accepted practice. On the other side, if I'm looking at a specific consultation and there are deficiencies in the notes, but all the other notes seem actually really good, and the patient and the doctor has explained, this was a particularly busy day and whatever, then I will say, look, the other notes are all of an excellent standard, so this seems to be a one-off. Or the complaint is this doctor didn't refer me for X, Y, or Z, but I see this pattern of anything comes up, there have been referrals made, even if unrelated to the complaint. I would certainly mention that as a part of formulating my opinion.
And apart from actually commenting on the actual notes in the case, do you give an overall impression at the end of it saying, look, I think there are serious competency concerns here and this person needs to be referred to the medical council? Do you give that kind of overall advice, or are you just providing the expert opinion on the notes in the case?
Again, I think it comes down to patient safety. So it's a little bit like ACC experts. If they feel that they're looking at a treatment injury case that there's a risk to public harm, then they will refer directly to the medical council and us, I think, as well.
Should be just to the medical council.
Just the medical council or the Ministry of Health.
Maybe the medical council then flick it on to
exactly,
us.
they do.
But if I have major concerns that yes, there's been a significant departure specifically related to the complaint, but honestly, everywhere I look, there are glaringly obvious signs of potential incompetence, then I won't necessarily list those issues, but it might influence my advice around management of the complaint that medical council referral might be.
So you give advice about management of the complaint separate from the expert opinion?
No. So part of my so what I'm asked to do sometimes is to advise remedial measures. Right. But I'm certainly asked if I think there's been a major competency issue, whether this provider should be referred to the medical council. Okay. So very occasionally, very rarely, I will say, I do think this requires referral to the medical council. Again, they won't necessarily get referred. And there are cases I see where the provider is referred and I've made no comment whatsoever. And that possibly relates more to the MOU with between HDC and the medical council around how many complaints you've had in X amount of time, etc.
The other thing I was going to talk about in the notes part of it was about hotkeys and the use of hotkeys, and I suppose a little bit going into the AI side of things there, of things being recorded that didn't happen or the notes not reflecting, because very often there is a conflict between what the patient remembers in the consult and what the doctor has written. What are your thoughts on hotkeys and how valid are they to use?
So, I've used hotkeys. I think if you use them appropriately, they're very helpful. However, if you're using them inappropriately, it's usually glaringly obvious. So I've seen cases where every time the patient goes in for whatever, they've ostensibly been given dietary advice, had all their peripheral pulses checked, had their carotids listened to, etc. Obviously that's totally inappropriate. Particularly when the patient never remembers taking their shoes and socks off or being examined in that way. And that, to me, that would be, when I see that, that's a red flag to me that there are issues with, or potential issues with this provider's management or attitude to management or whatever. So if used judiciously to improve the quality of your notes because it means you're not having to type so much, then I think perfectly reasonable. But as you say, possibly less likely to be an issue with the use of AI. And I mean, I've had personal experience of AI as a patient, hallucinating about having my range of shoulder movements checked, or my strength of my arms checked when it was just a range of shoulder movements. And I'm not quite sure how it determined that my strength was normal when it wasn't actually specifically discussed during the consult. But I think it still remains the responsibility of the provider to ensure that the notes are accurately represent what went on and are accurate, whether it's been generated by AI or not. But just be aware of the hallucination phenomenon and the risks that might pose.
I think it's interesting. I know that I personally have been to see healthcare providers and who have handwritten their notes or typed their notes in, and they hallucinate. It's not just AI that hallucinates. It's quite interesting to me. But I think at the end of the day, we need to check our notes to make sure they're accurate, because it's immediately obvious, as you say, to the patient.
Absolutely. And I think, honestly, there've been times I've gone to look back on notes and realised that I've stopped halfway through for some reason and never got back to finishing them. And it's really scary. And I know our practice had a way of checking that if no notes had been entered, then you were prompted that this has happened and to go back and do some notes on the day, which is great. I don't know how many practices use that, but it is so easy to get distracted or whatever, and your notes certainly aren't as good as they usually are, and it's usually when they're most critical, of course, that that's going to happen.
Yes.
We've
all had those moments.
Yeah, just got to acknowledge that. But again, I think that comes back to my point of, if I'm looking at notes unrelated to the complaint, it's often quite obvious that this was a hiccup rather than a trend, and that deserves consideration.
Can I just talk about when you were providing your opinion? Once you've provided it, do you ever have a discussion with the decision maker at the HDC? And do they ever question you about it and ask you to take another look? Right.
So basically there's never been an occasion where they would say, "Oh, look, we really want you to enable us to breach this, doctor. Can you do X, Y, or Z?" Never happened. They might come back and ask me to explain if I've been a bit technical in my opinion, to explain what it means or whatever. Or if it's not entirely clear, they might ask me to discuss or clarify how I came about my opinion in terms of degree of departure, for example. But I'm not so much from within the organisation, but I'm certainly happy to consider my opinion and reconsider my opinion based on feedback from both the provider and the complainant. And sometimes the provider will come back and just remind me of something they put in a subsequent response that I hadn't looked at, or come back with some clinical justification for me to change my opinion. And I certainly consider those and often do reconsider my opinion in light of information that might come back in that context.
We were having a discussion in the previous podcast that we were recording about expert opinions, and we've seen examples of where an expert has changed their opinion of how severe a departure was based on the emotional response from the complainant as opposed to any new clinical information. So you said that you take into account, obviously, the complainant's response to your opinion. Do you want to comment on that at all?
Yeah, I'd have to say that I have had far fewer times that I might have changed my advice in response to a complainant's feedback. With the complainant, it's often more about explaining more clearly the rationale behind my decision. So, and sometimes the feedback is a misinterpretation of what I've written. So clarification in that regard can be quite helpful. There's only been once where there was just persistent feedback from a complainant, which and it wasn't going. They weren't going to listen to me. They were determined that this doctor should be struck off, etc., etc. And I said, I'm quite happy to get another pair to offer fresh advice from the start, and if it differs from mine, well, so be it. but please, this is the only way this is going to be resolved from my point of view. And the peer had exactly the same conclusions as me. Unfortunately, the consumer's not satisfied, but...
Do you often get peer? I mean, I know sometimes with radiology experts, they actually ask other radiologists, what do you think of this? Is there a group of HDC GP experts who get together and discuss cases and think, what do you think? How would you call this mild? Would you call this moderate? Do you have a kind of a peer group for HDC advisors?
I mean, it's not a peer group of HDC advisors, but I use my own peer group, which is quite a large peer group because it's a big group practice. And it always obviously anonymised, but just to discuss principles and get kind of a feel for what what might be common management or accepted management amongst that group. And I'll often, or maybe not often, but I might mention that in my response.
Yes, we've noticed that. I consider that my peers would regard this as being
right. X, Y, Z. Yeah. So it's. I mean, within providing the response, what I'm required to do essentially is to quantify the degree of departure from accepted practice, and that brings up the issue of what is accepted practice, but there's also issues I face, which is common practice versus acceptable practice. So I know it's common practice for medication errors to be made. Is it acceptable to make a medication error? Is it accepted practice to prescribe, twice as much paracetamol for this child based on body weight as they should be taking, even if it was accidental or whatever? So, there's those dilemmas I'm always having to look at. But on the other side of the coin, reasonably frequent complaints from people that have been taking Zopiclone regularly for years and years and years, and then suddenly decide, oh, my doctor's been doing the wrong thing because I've read it shouldn't be given, it shouldn't be used long term. What does New Zealand formulary say? Maximum of 28 days. A maximum dose 7.5 milligrams. But in that situation, I'll say, well, it certainly wasn't prescribing it for 3 years continuously wasn't consistent with best practice. But looking at some of the BPAC publications on the frequency with which this is done, it's actually consistent with common practice. So those would be factors that the decision maker needs to consider.
And presumably, if somewhere in the notes was a mention of a discussion about reducing and stopping and patient decline, would that make
sadly
a difference?
Not? That would make a huge difference. But sadly, I don't see it as frequently as I would advise.
Because you get the complaints about not prescribing Zopiclone for patients who want it, and then prescribing Zopiclone for the patients who. It's just like Yeah,
and I think a case in point with that situation is opioid prescribing, and we get a lot of complaints around opioid prescribing, but as many about it being stopped as started. So we could have a whole session on opioid prescribing, but save that for another day maybe.
Thanks for answering so many questions, David. I know we've got a whole lot more. So I think what we'll do is we will end this part 1 and we will see you again for part 2. So thank you to our listeners who are listening to this podcast. I hope it's been helpful, and we hope that you'll tune in for our next part 2 of hearing from Dr. David Maplesden, the HDC in-house GP expert. If you like Medical Protection podcasts, please subscribe and leave a review. If you would like a podcast on a specific topic, please email nzpodcasts@medicalprotection.org. Thanks, David.
Thank you.